Thanks, Dr. Thacker and Dr. Wright, and SAGES for giving me the opportunity to speak today. These are my disclosures. Enhanced recovery pathways, originally introduced in the 1990s, seek to reduce physiologic stress and maintain physiologic homeostasis in the perioperative period. This is achieved through development of multidisciplinary perioperative care pathways, which are evidence-based. A paradigm shift with the ERAS approach is basically to transition from a physician-centric system to a patient-centered model. ERAS is not simply a single rigid protocol, but a dynamic multidisciplinary team approach, which is able to adapt to the best-known practices currently available for a specific disease and procedure. The majority of ERAS studies have mainly focused on immediate inpatient recovery outcomes, and there's a significant amount of literature to support that enhanced recovery protocols result in decreased length of stay and complications without increasing readmissions and cost. It remains uncertain, with the exception of a few studies, whether enhanced recovery pathways impact patient-reported outcomes beyond discharge and throughout the recovery trajectory. There have been several meta-analyses performed over the past 5 years, and of course the original one being in the colorectal surgery literature, which have shown these benefits. This study involved 16 randomized trials with over 2,300 patients and basically showed a decrease in length of stay by 2.3 days. Further analyses revealed a reduction in the overall morbidity, specifically for the non-surgical complications. In 2014, the American College of Surgeons, NSQIP, incorporated enhanced recovery process and outcome variables into a data platform. They went on to launch a pilot study, which was to support implementation of enhanced recovery pathways for colorectal surgery in NSQIP hospitals. They identified 15 hospitals as being high outliers for length of stay. They then compared outcomes to before and after implementation, and also compared to a cohort of control hospitals in a propensity-matched analysis. This study revealed that in the pilot hospitals, the length of stay was decreased by 1.7 days, compared to only a 0.4-day decrease for the control hospitals. There also was no difference in readmission, and there was a decreased morbidity for the post-implementation pilot patients. So enhanced recovery pathways have essentially become standard of care for patients undergoing colorectal surgery, as we have heard. So what is the evidence for the other general surgical specialties? This is a meta-analysis of patients undergoing hepatic resection, and it just basically states the outcomes. It was 7 randomized trials. The end result of this meta-analysis revealed a length of stay 3 days shorter, faster return of bowel function, and decreased overall complications. The next meta-analysis was in patients with gastric cancer who underwent laparoscopic gastrectomy. This analysis included 6 randomized trials of around 400 patients, which again showed decreased length of stay by 3 days, and in this case, decreased direct costs, again without increasing complications or readmissions. In the bariatric surgery patients, a meta-analysis of 13 studies and over 6,000 patients showed a decrease of length of stay by 1.5 days. And interestingly, this meta-analysis also showed a decrease in operative time by 20 minutes after standardizing perioperative techniques. A pooled analysis of these patients showed a decreased morbidity favoring the enhanced recovery patients, but did not reach statistical significance. So approximately 3 years ago, we implemented a ERAS hernia-specific program. We developed hernia clinical-specific pathways. We developed a hernia-specific ERAS order set, and most importantly, patient education materials. We also standardized teaching and developed a way that we can tag ERAS patients on our preoperative order sets without disrupting clinical flow. The results of our study, which will be discussed in detail at the next session, basically showed that the length of stay decreased by 1 day in the post-ERAS patients. And interestingly, the ERAS patients saved approximately $2,000 per case for an overall savings of more than $500,000 during the study period, which was basically 18 months post-implementation. Another earlier study by Dr. Novitsky's group also showed multiple benefits of ERAS program implementation, and these were in patients undergoing abdominal wall reconstruction. These patients had faster recovery of bowel function, decreased length of stay of 2 days. They also had lower 90-day readmission rates. So now we know that there's significant benefits in regards to immediate outcomes. Let's dive a little deeper. So does compliance matter when we have overall improved outcomes following implementation of our ERAS programs? I would argue yes, it does, as there have been several studies in the colorectal literature which reveal that increased adherence to ERAS protocols improve outcomes. Here's a study from the McGill group, which basically shows that the increased number of enhanced recovery elements improves overall successful recovery and decreases complications. Another study by the same group also identified positive and negative predictors of adherence. Some negative predictors that were identified was postoperative nausea and vomiting, late arrival to the surgery ward, basically after 6 p.m. following surgery, and whether they underwent rectal resection. A positive predictor was placement of an epidural. So let's get to what really matters, which is patient-reported outcomes. These are measures that come directly from the patient without interpretation from the clinician or anyone else. It's a way for providers to really focus on what's important to the patients and characterize biopsychosocial recovery benchmarks such as nutritional intake, physical function, and social interaction, just to name a few. In late December of 2016, almost a year ago, a group of international experts met, one being Dr. Thacker, and developed consensus statements around patient-reported outcomes in the context of enhanced recovery protocols. The consensus statements were, patient-reported outcomes provide an opportunity to improve clinical care and assess quality. Institutions should consistently document patient-reported outcomes and enhanced recovery pathways. An enhanced recovery pathway, patient-reported outcomes should be collected preoperatively at baseline during the immediate postoperative time period and after hospital discharge. This point was made because we want to collect at multiple time points to really capture the recovery trajectory. We know that patients' health status falls immediately following surgery, and then it takes around 2 weeks to a month to return to a new baseline. The top graph shows that this process should be more rapid, and the new intervention being implementation of the ERAS protocol. The blue table basically shows the important domains of patient-reported outcomes, and then on the bottom are examples of measurement tools that can be collected at various time points. So the working group concluded in 2016, almost 2017, that in the immediate postoperative setting, they felt that the quality of recovery 15 score was the most optimal measurement tool, and that after discharge at 30 days and 90 days, World Health Organization Disability Scale, or a tailored use of the patient-reported outcome measurement information system was optimal. So the working group identified over 600 studies that involved patient-reported outcomes. This is a busy slide, but they basically narrowed down these 600 studies to 13 studies that were in context of enhanced recovery. And this slide is basically to show you that it spans multiple surgical specialties, and the red boxes show where they had positive outcomes after implementation of ERAS protocols. The most recent study of that table was a study by Wang and colleagues. It involved over 100 patients. It was prospective and used the following patient-reported outcome measures. They collected data at multiple time points up to 30 days following surgery. The patients in the ERAS group were quicker to get out of bed, had quicker return of bowel function, and a decreased length of stay by 3 days. There also was no difference in morbidity between the two groups. Impressively, the response rate was 96%, and the ERAS group had higher scores at 3 weeks in regards to global quality of life, physical functioning, role functioning, emotional functioning, cognitive functioning, and also had lower scores, which mean they had less pain, a better appetite, less GI complaints, and financial difficulties, as well as a more positive perspective of future health. So in summary, given the growing evidence of the benefits of enhanced recovery pathways, we should widely adopt these into our practice. We also should get more granular with the data and really study adherence and compliance and see if we can further improve our outcomes. We also should utilize measurement tools that are sensitive and validated to the surgical patient that also capture the recovery trajectory. It is also important and difficult a challenge for us personally, but to develop an optimal method of collecting these patient-reported outcomes and incorporate these into the electronic medical record. And lastly, it is important to establish benchmark quality patient-centric metrics to better educate our patients regarding expectations and goals following surgery. This slide is a slide to remind us all how many resources are available on the SAGES website, thanks to the hard work of the SMART committee. There's a Facebook group that you can join. There's a manual that will be even more updated soon. It has a very nice interactive SMART bowel pathway. And then there's many examples of pathways from multiple groups that span various specialties. Thank you.